The good news is there is help if you recognize I need these things in you. However, we have to approach it as clinicians. We have to think about their age of onset of use as well as the reasons for substance use. So we can't just tell people, oh, you're drinking, go here next. We have to consider these things when we do treat somebody in the elderly. You know, what is their attitude about substance use? As I said, you know, the baby boomers, not a problem. They don't have any reservations about using drugs. What do they need to help them recover? And assess their support network. Do they have one or not? Then you're gonna have to, fill in where the need is. We also have to take a person-centered approach to emphasize values, needs, and a preference. Meaning, we gotta be age sensitive because they do have physical needs because they often have difficulty moving, hearing, seeing. So those are challenges. So you can't tell a patient who, is stuck to a wheelchair, go to AA. Right? At that point, they need a higher level of care. Hearing and vision, they can't hear or see well. It's hard for them to be in a group and discuss their issues. Of course, the memory and attention is not as good, as well as, how well will they learn the skills they need to cope? Because they will, we need to repeat the information. We got to go at a lower pace. Age preferences, right? Some people would rather be among their peers of the same age than to be mixed with some 20-year-old meth addicts. I hear this from patients too. It's like, I don't want to go to that AA because, there's a bunch of 20-year-olds and they're talking about, fentanyl. I'm an alcoholic, doc. I need to be around people, the same places I am. Those are the things we need to consider instead of just saying, okay, go see a psychiatrist, go see an addiction specialist. You gotta figure out where the challenges are with these patients because it's different compared to somebody who's 30 or 40 years old dealing with substances. And of course, if they're lucky, they get a caregiver, daughter, niece, grandchild. They also need to know and be included in all the treatment services because do you think grandma's gonna remember everything? Highly doubt it. And so you gotta give them also the education and resources. You can have access to care managers and this will improve their chance of recovery. Why do we need to consider the caregiver? Because they will get fatigue and burnout. I see this a lot. Like patients come into the hospital, this is their 10th admission for detox. We try to call, the niece, grandson, daughter, they're like, I'm done. You take care of it. I'm exhausted from it. So we gotta make sure we support them and give them the help that they need. There are places where you can get help. I think it's Al-Anon, is that right? Where the family, can go and get help because they're dealing with a family member with addiction. Okay, remember that screening tool that I used? Just because you may have answered to yourself. Not all of them will need formal treatment. Okay? So if you are in the mild to moderate, the doctor would say, hey, I think you need to slow down or avoid alcohol or avoid whatever, or we need to slow down the pain pills. Just educating them. Sometimes when somebody's dealing with substances, they keep going and going and going, and then it sort of is a cry for help. And so when somebody recognizes that, they just feel like, wow, somebody is hearing me. Somebody actually knows I'm suffering and I'm using bad things to deal with it. So we acknowledge that. And we tell them, what can I do to help you? Of course, if they have moderate to severe substance use, formal treatment may be necessary. If they really go through bad withdrawals, not just with alcohol, but with opiates, and anybody heard of kratom? Yeah. I mean, I don't know if it's popular now, as it was 10 years ago, but I've had to detox people off kratom with Suboxone, which is an opiate agonist. It can't be that bad, because it does hit the opioid receptors. That's why they like it, because it's easy to get. All right, residential treatment. I think it's very important, depending on how bad it is. I always recommend that if you have to go to detox, inpatient detox, you need residential. Because an alcoholic's brain does not change for the good until 30 days after they quit drinking. Why? When you have tampered the part of your brain where the alcohol sits, and it's called GABA. GABA is the inhibitor, and glutamate is the activator. So GABA is taking over and is sitting in there. All of a sudden you quit drinking, you may have gone through the detox, but your brain is not detoxed. That's why it's very important to get these patients to continue to get sober, in the first 30, 60, 90 days. Because their brain still needs time to change. That's why they crave. All right. Once they've done residential, is partial hospitalization, intensive outpatient treatment. These are like days where they go into an outpatient center, and several days a week, several hours, and they get further help with counseling and group. And of course, MAP. Anybody know what that is?
Medicated assisted.
Yeah, medication assisted treatment. It's still better for them to, maybe they need to get medications because they're still struggling with opioids. But how many people know here that there are MAP options for alcohol? Yeah, the ones that, work with me, because I tell them that all the time. I was like, why are these patients coming in with alcohol use disorder and they're not getting a camper state, which will help tamper those cravings? Naltrexone is not just used for opiate use problems. It can be used for alcohol. It's been studied, and it works. So there are still options for alcohol use. And unfortunately, we tend to forget that because we're so focused on the opiates when they're inpatient.